As Mark said, I'm Doreen Putnam. I've been a dementia practitioner for over 25 years. And not only from a professional standpoint, but also I've had dementia in my family. My mom had vascular dementia. My husband had mild cognitive impairment and died of a traumatic brain injury, which falls under the dementia category as well. I've had my consulting business for about 6.5 years, and you can see some of the things that I've done in this field. I'm currently working with families, doing training like this, doing training, certification, and in-service training for professional caregivers and community education as well. And I've worked in the field in several different capacities. So this is a quote that I love, and it applies to all of us. This is a Rosalind Carter quote. There are 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. We all fall into one of those categories at some point in our lives. At this point in time, Alzheimer's disease is really considered a tsunami. It's out of control. The numbers continue to increase when we have no medications to slow down or stop the progression of the disease. We have over 6 million Americans right now that have been diagnosed. That doesn't include everyone who hasn't even been to a doctor yet or has not been diagnosed. There are over 44 million people in the world with this disease. And as you can see in Pennsylvania, 415,000. By 2050, if we don't have a cure, a medication, treatment, those numbers are going to triple. And that's a very overwhelming kind of thought to consider. But we're hopeful that we will have some sort of a cure. The goal is 2025. I don't know if we're going to make that or not, but we'll see. We're going to talk about several things today. The difference between dementia and Alzheimer's disease, some of the commonalities between them, what physically happens to the brain. And to me, that's an important piece because a lot of people don't understand what's actually happening. And once they do, they tend to be more compassionate and more have more patience with their loved ones when they understand what's really happening. We're going to breeze through 10 warning signs because that's a whole presentation in itself. And we'll touch base on the risk factors and communication skills. Okay. So the question is Alzheimer's a form of dementia? Is dementia a form of Alzheimer's? And some of you may or may not know that. You don't know the answer, but Alzheimer's is a form of dementia. There are many types of dementia, and that is only just one form. And doctors have told us, or researchers, they think there could be as many as 80 different types of Alzheimer's disease. It's not just one disease. So here's a definition from the Alzheimer's Foundation of America. Dementia is that general term that describes a group of symptoms. Okay, dementia refers to symptoms, and it's loss of cognitive ability, your memory, judgment, language, complex skills, other intellectual functions that are caused by permanent damage or death to the nerve cells in the brain. Okay, dementia is not a disease. It refers to symptoms. If I have a sore throat, that's a symptom of something. It could be allergies. I could have a cold. It could be any other flu. It could be in any number of things. So I want you to realize that the term dementia refers to symptoms, not the name of a disease. So what is a dementia? Dementia is considered an umbrella term, and we're going to talk a little bit more about that. So I said it is not a disease, okay? It does refer to a group of symptoms related to loss of cognitive ability. It affects the patient's executive functions, the mental process that allows them to connect the past, the present, and the future. And just some examples at the bottom of the slide: their ability to think, remember, reason, plan, organize, and implement activities, problem solve, retain information. All of those things are part of what we call our executive functions, and they're not able to do that. And they may be able to do some of that, but eventually they're going to lose all of that ability. So we do have some causes symptoms that people deal with that look like dementia. We call them dementia-like behaviors, but they really are not dementia. And as you'll notice at the top of the screen here, they're reversible, okay? So this is not all of them. This is a sample of them. Malnutrition and dehydration are two major factors. We see this happening with people who've lived alone and are moving into residential facilities. These are two things that the staff has to work with them very quickly. Sleep apnea, okay? When you have sleep apnea, you're losing the amount of oxygen and blood that you need in your brain, and this can cause dementia-like behavior. Vitamin B12 deficiency, cross-medication and over-medication of drugs. Those are kind of self-explanatory. The cross-medication is one drug working against another drug so that neither one of them are effective. I've got sleep apnea down twice. I'll have to change that, sorry. Social drugs, alcohol, other kind of social drugs that people have had over the years. Metabolic imbalances related to the kidney, the liver, and the thyroid. Depression and urinary tract infections. Someone who has if any of you have seen this or perhaps experienced it yourself, someone will go to bed at night, will have a urinary tract infection, and when they wake up in the morning, their behaviors are very, very different. But these are dementia-like behaviors that, if they're caught early enough, can be reversed. If it's a long-term thing, like with social drugs, then that's not necessarily the case. Now, just to remember the picture here, all right? We talk about dementia as being an umbrella term. I'm not going to go into all of these. This is another, again, whole training in and of itself. These are the more common forms of dementia that we know about right now, that's more, we hear more about, we see in the newspapers, on social media. We see Hollywood people who are perhaps exhibiting some of these. Alzheimer's disease, vascular dementia, Parkinsonian dementia, dementia with Lewy bodies. That's another prominent one that's beginning to gain more recognition. Frontotemporal degeneration, we refer to it as FTD. Mixed dementia, meaning you have two or more forms of dementia. Early onset Alzheimer's is people who are under 65, where Alzheimer's is 65 and older. Some people in their 20s and 30s develop early onset Alzheimer's disease, and stop to think what that must mean to their family. CTE, chronic traumatic encephalopathy. Football players and sports people who have had constant kind of battering to the head, whether it's preconcussive or concussions, that over a long term, and they develop CTE. Down syndrome is a form of dementia also, because the gene that is related to Down syndrome, the gene of Down syndrome is related to the gene of Alzheimer's disease. And we know that if our Down syndrome patients live long enough, they will develop Alzheimer's disease. Huntington's, hydrocephalus, Creutzfeldt-Jakob disease, used to be known as mad cow disease. You may recognize that name. Traumatic brain injury, people who've had strokes. So these are all, not all of them, but the major ones that we are hear most about at this point in time that are, as you can see at the top, irreversible. It's not possible to reverse these once you have that diagnosis, okay? So some general information about dementias as a whole. I just mentioned Alzheimer's disease is 65 and over. Dementia with Lewy body and vascular dementia, frontotemporal, those are the four more prominent forms of dementia that we hear about now. They're all very different, but there are some commonalities, and we're going to talk about those in a minute. Mixed dementia, which I mentioned, combines two or more. NIH has said that 54% of people with AD also have another form of dementia that they can tell through autopsy reports. Down syndromes, 50% of people who are 50 years of age have Alzheimer's disease. So this is something that is very prevalent throughout our society. And as I said earlier, the numbers are continuing to increase. Some of the common traits. Many times it's difficult to determine which type of dementia someone has. If a patient is going to a primary care doctor, they may not have the knowledge base or the specialty in this. You hopefully will find a neurologist but not all neurologists deal with dementia. Many of them deal with other issues. So sometimes it's difficult to get an accurate diagnosis within a reasonable period of time. I've had some patients and clients that I've dealt with, it's been 3 or 4 years before they can get an actual diagnosis, and that's very difficult on the families. It makes it hard to distinguish what type they have in the early stages because they're not seeing enough of the behaviors or the other characteristics. Dementia is not part of the normal aging process. Forgetfulness is, but dementia is not. That's a myth. With some forms of dementia, Alzheimer's develops slowly, like with Alzheimer's disease, but in many cases, it's more rapid with LBD is Lewy body dementia, early onset. There are some other diseases where FTD, especially time of death is maybe 5 to 8 years after diagnosis, where Alzheimer's might be 10, 12 years. It could be 20 years if it turns out that the person is healthy otherwise. Another common trait is that we find families that are in denial. This is a very common trait, and many times it prevents them from getting the kind of help that they need early enough because of the denial or the guilt that's there. And many times spouses are covering for each other, and that makes it difficult for family to do anything about helping them. This is an important factor that a lot of people don't understand. Alzheimer's disease specifically begins to develop in the brain 20 to 30 years prior to any symptoms showing. And they know this from the autopsies that they have done, 20 to 30 years. So all of us on the call right now could already have Alzheimer's developing in our brain, and it won't show for another 20. And when I say won't show, the behaviors won't be there until another 20 or 30 years. And if you or a loved one, people that you're working with have questions, it's important to get to your PCP, a gerontologist, and certainly a neurologist. Okay. So some specific things about Alzheimer's disease that I'm going to talk about tonight, because that's the most prominent one and the name that most people hear the most. It's the most common form of dementia. It's progressive. All of these dementias are progressive, and they're all terminal, which is something that a lot of people don't understand. It is not selective to race, sex, religion, culture, any kind of category that you want to come up with. We are all vulnerable to this disease. And it's more prevalent in women. I don't know if you've got your mic open. Does anybody know why? Women live longer than men. And consequently, we see more women with this disease than we do men. We're really at epidemic or tsunami levels, and I've already talked about the numbers for 2050. What happens with these dementias is the brain is being destroyed, the brain is dying, and there is no cure for any of these diseases at this point. Now, you're going to say there are medications out there, and there are. Those medications, if you look at the third bullet, the medications are recommended to manage behaviors. The statement in the red, medications do not slow down the progression of the disease, reverse it, or prevent it, not at this point in time. And many families do not understand this. They think that it's going to make a difference, and it will with the behaviors. But if someone's been on the medication for a period of time and you take that medication away, you're going to see where the disease has advanced. And the medication has helped to mask that to some degree. These diseases are terminal. There's a number of testing techniques that they can use. The primary one that they use for all of them is verified through autopsy process once someone has died. And that's another whole program on the types of testing that they do and what they are looking for when they do the testing. Doctors can be 90 to 95% sure of what the diagnosis is. PET scans help with Alzheimer's disease, and we're going to take a look at that in a couple of minutes. For those of you that aren't familiar, ADLs refers to activities of daily living. the person's ability to shower, dress themselves, take care of their bathroom responsibilities, eat, those kinds of things that we all take for granted, begin to decline, and it's a continuous decline. You might see one of the ADLs being declining more quickly than some of the others, but eventually as the disease progresses, they're all going to decline, which means they need more help and eventually will need 100% care. One of the more difficult things that I have to deal with, and I think anybody who works in the field has to deal with, is the grief that the family members are going through. That starts when a family member, whether it's a primary caregiver or perhaps children in the family, begin to realize something is wrong. That grief begins to set in, and that goes all the way through the process, whether it's 5 years, 10 years, or 12 years. And of course, when death comes, that's another form of grief that they have to deal with as well. The medications we've talked about, but in Alzheimer's, we talk about mild, moderate, and severe stages of Alzheimer's disease. And each of those stages has particular characteristics that kind of identify where the person is in the disease process. And that's something that doctors would go over with family members to get an idea of how fast the disease is progressing. The other thing too is I always encourage family members to keep I hate to use the word journal because some people kind of back away from that, but notes, just bullet points of changes that you are seeing for that person over a period of time, so that when you go to talk to a doctor 6 months at a time or a year at a time, you've got some concrete information to take with you. We know that the brain controls everything that we do, absolutely everything that we do, from moving our hands to speaking to seeing. And as these diseases, especially Alzheimer's disease, which we're talking about now, moves through the brain, it destroys the cells in the brain, it destroys sections of the brain, and that begins to affect how people are able to respond, whether it's their walking, whether it's their speech, whether it's understanding words that people have spoken to them. It depends on what part of the brain that the Alzheimer's has settled into as to how the person is responding. So the 10 warning signs, this is something that's been developed by the Alzheimer's Association. And they indicate that if a patient or person has 3 or more of these warning signs, they should talk with a doctor. I'm just going to go through the 10 to begin with, and then we'll look at each one of them just briefly. Memory loss, challenges with problem solving, the inability to complete daily tasks, which is part of the ADLs, word problems, problems with remembering time and place and figuring that out, misplacing items, decreased or poor judgment, personality changes, isolation, and visual images and perceptual changes. So let's take a look at each one of these. And as I said, I'm not going to go through in great detail, but you can see the screen in front of you. Memory loss is one of the first things that we see with Alzheimer's disease. It's not true for some of the other forms of dementia. It's not true with Parkinson's, not necessarily true with FTD. It all depends on the type of dementia that someone has. Repetitive questions and repetitive behaviors we see with Alzheimer's disease. Relying on family for information and backup when they can't remember certain things. Challenges with problem solving. Yeah, some people can't remember how to open a can of soup. They can't follow recipes, or they don't know what to do with the drill that's in the garage that they've been using for the last 30 years. They can't plan things like vacations or birthday celebrations. Don't remember how to use a cell phone or calculator. These are all initial signs that something is happening in the brain, and these are things that family members should be able to pick up on. Inability to complete daily tasks, whether it's at work, meeting deadlines, not remembering how to score football games that they've watched for years and years. I had one patient in one of my support groups in Rhode Island. I've just moved here 2.5 years ago, but I had been in Rhode Island for an extended period of time. She came home from school one day and told her husband, in the middle of the school year, told her husband she'd been fired and she didn't know why. And she didn't have Alzheimer's disease. They thought she did, but it didn't know what it turned out to be FTD. But she couldn't complete her daily tasks at work. She wasn't meeting the guidelines. She wasn't doing the things that teachers are required to do. And she never did understand why she had been fired from her job. Word problems are a major key, and the fact that something is not quite right. They can't come up with nouns. They can't come up with words. Now, as we all age, we do begin to get forgetful, but there's a difference between forgetfulness and memory loss. Forgetfulness is temporary. Happened to me today when I was talking with someone at a meeting, but within 10 seconds, I had it. Memory loss means it won't come back to you ever. Whatever information that you are trying to say will not be there because it's gone. It limits conversation. And the other thing that we find is that patients don't initiate conversations. They might respond with yes or no because those are easy answers, but they don't initiate conversation like they might have always done. Problems with time and place, not knowing the month and season of the year, confusing doctor's appointments, all sorts of, you can think of your own experiences in your own family or people that you know. Misplacing keys and car keys and glasses. We all might do that, but we can trace back and figure out where we left it. Someone who has dementia is not capable of doing that anymore, and then they get distracted and move on to something else. Storing things where they don't belong, salt and pepper in the freezer. Can't remember how to retrace their steps in order to find the things that they've misplaced. Poor judgment. Someone who was a painter who would climb a second-story ladder when he shouldn't be up there, leaving the gas burner on. We have all sorts of stories of women with bathrobes that have caught on fire because they forgot to turn the burner off when they were baking or making eggs or whatever. We see personality changes, all sorts of kind of combinations there depending on the individual. Isolation. Someone who has dementia begins to isolate because they're uncomfortable being in social settings. It's easier for them to be by themselves where they're not feel like they're being tested or questioned. They have their own comfort zone that they want to stay in. As the disease has progressed, many family members will say, well, all he wants to do is sit in front of the TV all day. Well, that's the comfort zone. They're comfortable there. That's their favorite chair. They're at home. They can watch TV programs that they've always liked. Visual images and perceptual changes. Newspapers. Some people will sit in a chair and look at a newspaper for 10 or 15 minutes, but never turn the page. And that's a sign that they're not registering what's on the page. Other people might be able to read the words, but they no longer have an understanding of what those words mean. The next to the last one, images in the mirror. Some people see themselves in a mirror, but they don't recognize themselves. They're remembering because of the memory loss. They're remembering what they looked like 20 years ago or 30 years ago. So this, say, older person who is 70, 75 years of age, they have no idea who this person is because they can't relate to that person. So sometimes we have to cover mirrors. Sometimes we have to remove them. Okay, so any questions at this point? Okay, so what physically happens to the brain? This is an important piece. This is what the human brain looks like. On the right is the front of the brain. To the left is the back, and the piece at the bottom, the little tail, that's the beginning of the spinal cord. Okay. You can see the what I call fissures that are here. They're fairly close together. This is a sheath that goes around all of the brain. Part of it's been removed, but you can see a difference in texture. But the fissures are all fairly close together, and that's going to be important. And I want you to remember that as we go on through here. Okay. I mentioned that we all know there are certain parts of the brain that have certain responsibilities, and this is just a sketch that gives you a little bit of an idea. The frontal lobe here is where we make our executive decisions. The temporal lobe, which is over the ears, the frontal lobe here on the left is the front of the brain, and you can see the stem here on the back of the brain. But each of these lobes within the brain have certain specific responsibilities to maintain what we normally do on a day-to-day basis. And when parts of the brain, those sections, become infected by this disease, or the brain cells are destroyed, then they're no longer able to function. And I'll just give you one simple example. The occipital lobe back here controls our visual abilities. I've had 2 patients that I worked with that they were having trouble. The family thought they were going blind. They took them to the eye doctor. There was absolutely nothing wrong with their eyes. Their eyes were functioning properly. And they both had dementia. The problem was that the occipital lobe here wasn't able to register what the eyes were seeing. So they had no way to function properly. Okay, that's just one example. But no matter what part of the brain is impacted, it's going to affect how the body responds to it. Here we have 2 examples of a healthy brain on the right and an Alzheimer's brain on the left. Now you can see how tight the fissures are here. We have a left lobe and a right lobe. I think you probably all know the right lobe controls the left side of our body. The left lobe controls the opposite side. Look at the difference in the size of the fissures between these 2 pictures. These are actual pictures of brains. You can also see where the brain has shrunk, and that's one of the major things that happens with these dementia, especially Alzheimer's disease. The brain begins to shrink. A normal brain weighs about 3 pounds. A fully diseased Alzheimer's brain only weighs 1 pound. So over the term of 5, 10, 15 years, whatever it might be, the brain is continuing to shrink and lose its ability to function properly. If we have someone that we see that only has 2/3 of their arm due to an injury or whatever, or an amputation, we don't expect that person to be able to do everything they always did with their right arm, because 2/3 of it is gone. And the same thing is true here. A fully developed Alzheimer's brain is 2/3 smaller and with function physically and functionally than a regular Alzheimer's brain. And that's what we can't see, and that's what people don't understand. Here's just a sketch again. You can see the difference in the size of the brain where it has shrunk. These are actually holes that are in the brain. What you were seeing before, was the outside of the brain. This is the inside of the brain. And as the brain dies and cells decline, it actually leaves holes in the brain. So this is not true, but this is an example. If this part of the brain controlled the heart, you know that the heart is not going to function. The person is going to die from a heart attack. If this part of the brain controls the liver, we're going to have liver dysfunction or kidney dysfunction. It depends on what part of the brain has been impacted. But this is what is actually happening. And because you're seeing these holes, you have a better understanding of why the brain is shrinking. It's collapsing in on itself. This is a picture of a PET scan. The front is at the top of the PET scan. The back of the head is at the bottom. This is a cross section, you have to realize, okay? Now, what you're seeing in blue here is, on both sides, is a normal brain structure, okay? What you're seeing in the gold and brown section on only 1/2 of the brain, there will be another half, but it's not there so that you can see the blue part. That's a fully diseased Alzheimer's brain. You can see how the basic evenness around here is not the case. You see the spaces in between. This portion of the brain should be down here. and look how much it has shrunk. Okay. Many people just assume that the brain is like a muscle, like our other parts of our body, and that's not the case. The brain has the consistency of Jell-O. Okay, so when it gets shaken with a sports hit, soccer ball, a fall, whatever it might be, that brain is going to move inside the skull. And for our dementia patients, the brain is already smaller, much smaller. There's going to be more potential damage because it's going to kind of rock around inside the skull when someone falls. And that's why falls are really important not to happen with our dementia patients. Okay, these are two different sets of PET scan images. The one at the top is showing negative, no Alzheimer's. The one at the bottom, which it says positive, is showing where the Alzheimer's disease is. Look how spread out through the brain that is. That's got to impact, I don't know what exactly where this horizontal cut is, and this it never did tell us, but you can see the difference. All the red area and the yellow around it are all Alzheimer's disease. And when you have that much Alzheimer's disease in your brain, you're just not capable of functioning like you normally would expect someone else to who doesn't have this disease. What we find in the brain with not only Alzheimer's, but some of the other diseases, as dementia diseases as well, is what we call neurons and plaque, amyloid plaque. And you can see on the left here, this is just a sketch, obviously, of what these are individual cells. And impulses go from the center of the cell to the end to make contact and tell us what to do with our hands and our fingers. On the right-hand side, you're seeing two different things, the neurofibrillary tangles, which are inside the center of the cell. Okay, so as those tangles impact the center of the cell is going to die. And when this cell dies, it begins to spread to the other cells. Now, the amyloid plaque, as you can see here, is between the cells. So what this ends up doing, and this isn't, I have another screen that I'll show you. What the amyloid plaque does is that it kind of suffocates or the areas where the impulses move from one area to another. It blocks the nerve pathways. And there's another slide coming up, which I'll show you in a second. They're both a form of protein, plaque, like we have on our teeth or in our arteries, if we have that kind of an issue. Tangles is a form of twisted protein, which we call tau, that forms inside the nerve cells and destroys it or kills it. The plaques, which are the beta amyloid, collect between the cells, blocks the impulses from being transmitted. And this is another example here. You can see the tangles inside this nerve. And these are the plaques that form between them, are blocking or choking off the pathways so that the cell might be healthy, but if the amyloid plaque is here, it's not going to allow the nerve to function properly. And if there's enough of this, even though the cell might be healthy, it's not going to be able to get the impulses through. So, okay. All right, any questions about the brain? Okay, we'll move on to risk factors. This is one of the biggest risks I ever took on safari when I was in South Africa. We actually spent time out in the savannah with 2 female lions. It was a great experience. I loved it. Okay, risk factors. Age we've talked a little bit about, but these are a little bit different statistics. For women who are 65 or over, 1 out of 6 women will have Alzheimer's disease and 1 out of 11 men. Okay. If you're 85 or over, you have a 33% chance of contracting the disease. And we know that 1 out of 3 people die with some form of dementia. I was talking with a couple of people today at that conference that I was at, and we were saying that 80, 85, 90% of people who are in nursing homes or memory care units, certainly memory care units, but nursing homes have some form of dementia. The numbers are very high. If you're over 71, it's 1 out of 16 women, it's still 1 out of 11 men. It increases as age increases. People have a question about genetics, and this is very complicated, but there are 2 types of genes that really make a difference. If you have what we call a risk gene, and they have all sorts of letters and numbers related to them, you have an increased risk of getting Alzheimer's disease, but it doesn't mean you're going to get it. It's kind of a flip of a coin, so to speak. However, if a person has the deterministic genes, and those are specific genes that have come genetically from parents and other relatives, you definitely will get the disease. And we find that people in their 30s and 40s and 50s begin to exhibit symptoms, perhaps with not only Alzheimer's, but some of the other forms of dementia, certainly early onset Alzheimer's here. But the deterministic gene is the one that makes the determination. Now, do you go and get genetic testing? That's always a question. Most insurance companies will not pay for that. They might, but most of them won't. If a person is showing signs, they might be more open to doing that, and your doctor might be more open to recommending that you have it done, especially if there are other children in the family that are under consideration as well. From a family history standpoint, the higher number of people in your family who have had Alzheimer's, the higher your risk. Again, it doesn't mean you're going to get it unless you have that deterministic gene, but it puts you more at risk. So the more people, let me state that over again. If you have people in your family in the same generation, your mother, her brother, and her sister that have Alzheimer's disease, or multiple generations, your grandmother, your mother have had the disease, you are more at risk. It doesn't mean you're going to get it, but you are certainly more at risk for it. We know that smokers are 2 times more likely to develop Alzheimer's disease, and that is primarily because when you smoke, let's go back to the sleep apnea. When you have sleep apnea, what you're doing is you're cutting off the oxygen supply to your brain at night when you sleep, as well as the blood supply. And the brain needs to survive on a lot of different chemicals and things that are in it, but it needs the blood and the oxygen in order to function properly. When you smoke, you are constricting those arteries that are in the brain, and that puts you more at risk for developing Alzheimer's disease. If you've been a long-term alcoholic, that's going to do a similar kind of thing, because we know alcohol restricts the blood vessels in the brain as well. People always wonder, what can I do? What can I do? And one of the things that the Alzheimer's Association recommends is to use the Mediterranean diet. And you can pick that up on your cell phone and take a look at it and see what it is. It recommends basically eating whole grains, fruits, veggies, fish, nuts, olive oil, and the appropriate quantity. That's what they recommend. And so if you're interested in looking at that, please follow through on that. The body mass index, the BMI, is also another indicator. And that, again, is something that you can look up online. It relates to your age and your weight, and it will tell you where you fall on the BMI as to whether you are within the range that you should be, whether you are overweight or whether you are obese, or in the opposite direction, underweight. And that's also another indicator. Head trauma, we see a lot of this with certainly our sports that males and females play, and falls that we have. This statistic is a little old, and I haven't, like 3 years maybe, I haven't seen a current one, but the NFL has indicated that 1/3 of its former NFL players have at least mild cognitive impairment. And if you read the news and see the reports on TV or on your social media, you see more people coming forward, the football players, the hockey players, soccer players that have had to leave or retire because of the head injuries and the dementia that they now have. We know that African Americans are 2 times more at risk for Alzheimer's disease, and Hispanics are 1.5 times more at risk. And that comes to a number of reasons for those statistics. Part of it is either lack of medical care or the ability to get medical care, and a number of other things related to their culture. Lack of physical exercise. They say we should exercise 1 hour, 5 days a week. And part of what that exercise does, it strengthens our muscles and our joints, but it also gets the blood flow moving in our body. And that's important to keep that blood flowing through our brain. You know, they say now that sitting is is comparable to what smoking was several years ago. And with COVID hopefully behind us now, you know, we've all done a lot of sitting over the last 1.5 years. So exercise is really important. Sometimes it's just walking. You don't have to walk for cardiac purposes fast. It's just making sure that your body is moving. Lack of stimulation for the brain is another risk factor. We know that. There are people will agree and disagree with this. I've seen researchers that have been on one side or the other, but anything that you can do to stimulate your brain, whether you've got special hobbies, whether you take on a new hobby, Sudoku is basically using math skills. That's not an appropriate stimulation for someone if they're a math teacher or an accountant, because they're using the same part of their brain that they use all day long. Just as crossword puzzles using words is not necessarily an appropriate activity for an English teacher or someone who's at the computer all the day. You want to find activities that are stimulating to your mind that are different in your leisure time than what you do on a daily basis in your work, because you need to stimulate other sections of your brain. Every so often I'll go through a stage where I'm right-handed, and I will go through a stage of practicing writing with my left hand, just as informing a different part of my brain to work at a different level. And I'll just give you one other thought on this. Instead of when you leave work, instead of going home the same way every day, the same streets, the same corners, go a different way, because when you go a different way, your brain has to work differently. When you're taking the same course to work and from work every single day, you go on automatic, and that's not healthy for your brain. So you want to change things up and go a different way. And the same thing with other activities that you do. Walk in a different direction. It does make a difference for your brain. Medical conditions we know are risk factors for people with dementia. Our cardiovascular issues are an important factor. High blood pressure, diabetes, those are all things. The heart and the brain are very much connected with each other. And what is good for the heart is good for the brain, and vice versa. We've already talked about the medication issue. We've talked about multiple generations and multiple people in the same generations. But the statement at the bottom is important. No matter how healthy you may appear to be, each of us is potentially at risk for one of the dementia diseases. It can hit people in random. You don't necessarily have to have someone in your family that's had Alzheimer's, but you may discover that you are one of the people that it just happens with, and there's no rhyme or reason for why it happens to hit specific individuals. Communication, okay, so these diagrams that I have here all represent different things related to communication. Let me go back before I continue on this. Does anybody have any question about risk factors? Okay, so communication with someone that has dementia is really critical. It's one of the things that when I'm consulting with families or doing training that I spend a lot of time on, and this is just, you know, a sample to make you aware of it more than anything else. When someone cannot recognize the words that we normally use, they can't communicate with us. And we know that people with dementia do not have the ability to function properly in our reality, our world. And as caregivers, whether we're family or professional caregivers, we have to figure out how to communicate with them in their world. And there are certain things that we can do. Many times they're successful, sometimes they're not. And you can't just give up because you've tried it once. You have to try it over and over again at different times of the day, or come back 5 minutes later after you've already said something or tried to communicate something. For some people with word issues, they may hear what you're saying, but they no longer remember the meaning of the word. For some forms of dementia like FTD, they begin to lose their ability to speak. So they can understand you, but the part of the brain that controls their speech no longer is allowing them to speak at all. So they have no speech whatsoever. So you have to figure out what really works best for the individual person. What works for one person will not necessarily work well for another person. So you have to play with that and figure out what's best. The other thing that I will say, and it's related to communication, is with someone dementia, with someone who has dementia, whether it's Alzheimer's or any other form, you never, I'll repeat it, never argue, because you can't win, because they're dealing with their reality. And if it's 2 o'clock in the afternoon and they think it's nighttime, you're not going to change their mind. Their reality is what it is, and you have to figure out as a caregiver the best way to still function with that person and communicate. And that's a very difficult task. It's a very difficult task because things can change from day to day. And as we know, working with that early, middle, and latter stages of the disease process, with no matter what form of dementia you have, each stage they begin to lose more of their ADLs and other things that we take for granted. And that can happen overnight. They also have moments of lucidity where they are just as clear as anything, and you're still treating them as if they have dementia. So you have to kind of cherish those lucid moments because they don't necessarily last very long, and you don't know when it will happen again. You know, for some families where the person doesn't recognize family members any longer or calls them by the wrong name, there may be days when they are just as lucid as anything and they know exactly who's sitting there with them. Other days they won't. And when patients begin to forget who family members are, that's a very difficult stage for family members to accept. So looking at effective communications, there are several things that we can do to help improve how we connect with people. I want to talk about fiblets first, which is right up here. Some of you may have heard this term before, and some of you may not have. They're called therapeutic fiblets, and it's a form of communication that we use to help the patient never to do anything that will harm them. They're little white lies, and this is a very difficult thing for families to learn how to do, but it's important for their success in communicating with people. Let me give you a couple of examples. I've been the executive senior director of 11 different memory care communities. And in one of my communities, we had a woman whose name was Anna. And after lunch, she always participated in the activities in the morning. But in the afternoon, after lunch, she immediately went and sat in a particular chair and would refuse to do any activities at all because she was waiting for her brother to come visit. He usually visited her in the afternoon. Well, what she wasn't capable of understanding was that her brother went to Florida for 6 months out of the year. So he wasn't going to be there every day or every other day to see her. So in order for us to work with her and to get her up and active, we had to use therapeutic fiblets with her. So one day we might say, Anna, it's raining very hard out today. I'm not sure your brother's going to be able to get here because the rain is so hard. In the wintertime, we might say, Anna, look at the snow out there. I don't think your brother's going to be able to get up the hill to get here. Anna, your brother called and he had a dentist appointment today, but he'll call you or stop by tomorrow. Those were all fiblets. None of those were true. But we satisfied her need at that point to know where her brother was and what he was doing. And once we were able to talk with her about why her brother wasn't there, she would get up and go on and do activities and continue to participate in whatever was going on that day. So therapeutic fiblets do have a purpose. In Anna's case, she was far enough along in the Alzheimer's disease process that we could use the same fiblet day after day after day, and she wouldn't remember that because she couldn't remember that we had told her the day before. So there are times when you have to use fiblets. Just another example, if you've got a loved one who needs to go to the doctors and they're saying, I'm not going, rather than telling them they're going to the doctor, maybe you would say, we're going to go get ice cream. You go get the ice cream and then you stop at the doctor's office. And by then, maybe the patient might be willing to go in. So you have to kind of play with this and learn how to do it. I talked with a man yesterday who's a new client, and we were talking about fiblets, and he said, I finally figured out how to do that. But he said, I'm so uncomfortable with it because I've been married for X number of years. I've never lied to my wife. And I feel like I'm lying to her now. And part of what I was saying to him, you're not lying, you're helping her. You know, this is a technique that we have to learn to use in the dementia field in order to be successful with communicating. So I don't know if any of you may have your own examples of things that you've done. You know, you may find as time goes on, you may need to do that. Music is very, very important to people with dementia. Short-term memory is stored in what we call the hippocampi. There are two hippocampus, one on each side of the brain, right near the center where the divide is. That stores short-term memory. And as with Alzheimer's disease, the hippocampi begins to shrink and dysfunction early on. That's why they have short-term memory loss. They cannot remember what they had for breakfast. They can't remember sometimes where they lived, what kind of work they had done, their kids' names, all sorts of things that come into play there. However, music is something that is stored in various parts of the brain. I'm reading a great book now that some of you might be interested in. Lisa Genova, Dr. Lisa Genova is the woman who wrote the book Still Alice, that the movie was made from, and she's written 5 different books about neurological dementia diseases. They're all fascinating to me. They might not be to all of you, but they are to me. But the one I'm reading now is her latest book called Remember. And it's scientifically how memories are formed in the brain and what forgetfulness means and what memory loss means. I'm only into like 4 chapters, but I'm fascinated by it. And one of the things that we've known for a number of years, is that music is stored in the part of the brain where long-term memory is stored. Music is so important. So when your loved one gets agitated, you turn on relaxing music. In many of our residential communities, excuse me, they'll put relaxing instrumental music on during mealtime because that's something that helps to calm the patients down. To put music on when your loved one is taking a nap or getting ready to go to bed at night can be very, very helpful. The other side of that is if you've got grandkids that are coming to visit and you're not quite sure what to do with them, get them to sing the national anthem and some of the perhaps church songs that your loved one might know, or Christmas songs, holiday songs. That lights up part of the brain that allows them to be active. And you'll be surprised how much they can remember. If someone has been involved in religious life, they will remember the Hail Mary. If that's been part of their life, they'll remember the Lord's Prayer, those kinds of things. So you can always relate to those. but music is really critical. Sense of humor is absolutely important. You have to learn to laugh at yourself and laugh with the resident, not at them, but with them. We don't want to laugh at them at all. And anytime you can turn a situation into a humorous situation, you're both going to feel better about it. There's a couple of videos on YouTube. One that I love, there are two that I love, but the first one is a mother who has, and father, who've just had, I think it's 5 or 6 children, and she's in bed and has all the kids around her, they're young, and the father starts making funny noises, and all 5 of these youngsters begin to laugh at the same time, and it becomes infectious, and you can't help but laugh with them. And it's a great thing to show someone when they're feeling down or whatever. The other one is a man, it's in France, I believe, who gets on a subway and has an iPad and just starts laughing every so often. And then people begin to look at him, and he laughs more and he laughs louder. And the next thing you know, he's got the whole subway car laughing with him. They're both great videos. If you haven't seen them, I would encourage you to take a look at them. So laughter and humor are really important factors, and humor comes in here on the left-hand side too. We want to speak slowly and clearly when we're talking with patients, because since the brain isn't functioning properly, we have to slow our speech down so they've got time to register what we're saying and hopefully be able to respond to that. So you don't want to drag your words out, but you want to be clear with what you're saying and also speak slower than your normal rate. We do know that with our Alzheimer's patients, if you're giving them directions, you only give them one direction at a time. You're clear what it is, and you give them one direction at a time. You don't say to someone, let's get up, we'll get your clothes on, put your shoes on, brush your teeth, and get ready to go to breakfast. That's too much information. It's, let's get out of bed this morning. Can you put your slippers on? So you take it step by step by step, so it's clear and it's slower. The one here on the left is eye level. You want to be eye level when you're talking with your loved one. If you are standing over someone who is sitting, that can be perceived as a threat by them because you're hovering over them. So you want to be at eye level, whether you're sitting at the same level, standing at the same level. You want to be able to look eye to eye with them, and so they can connect with you that way, especially if their speech is more limited. The other piece in this upper left-hand corner is facing them face to face. One of the things we train our professional caregivers to do is to stand face to face when they're talking with a patient, because if you are on the side, we know many of our elderly patients have peripheral vision issues and they can't see the people on either side of them, so they don't know they're being spoken to. Or if you stand behind them, they have no idea you're talking to them, even if you use their name. You need to come around in the front and stand face to face, eye to eye, so that they know they can connect with you and that they have a better chance of understanding what you're saying. Distractions are a major thing that happens. I don't know how many of you have ever walked into a household to visit a client or a friend, and the television is blaring or music is blaring. It's hard to concentrate on what you're saying when you've got this distraction. So you want to remove as many distractions as possible when you're trying to communicate with your loved one. Loud music, we know, is a distraction. Bright lights are a distraction. Noise on the street, barking dogs, kids running through the house, grandkids that might be visiting who are yelling or, just being kids. All of those are distractions for someone with dementia. They can't concentrate on trying to communicate with a loved one when all of this other stuff is going on around them. Just another example, when you prepare food for them, it should be on a plain plate, not on a plate that's got a lot of flowers or design to it, because they get caught up in the design and forget to eat. So, a plain plate or a soup bowl, whatever it might be, is much better for them, because the other is a distraction. Music doesn't fall under that category unless it's loud and music that they don't like. Music can be very helpful at times. This one I use is just respect. You know, there are elders, there are adults, they're not children. And we need to respect our dementia patients like we would anyone else. We don't talk to them, in baby talk. We don't talk about them in front of them, just like you don't do that with children. I don't know how many car dealerships my husband and I have gone to, and I've been asking the questions, and the car dealer is looking at my husband to answer the questions. I get really frustrated with that. Many times doctors will do the same thing, or nurses. So we need to respect them as adults. The last one that we have on the screen here is up in the right-hand corner, the repeat. We know that repetitive language and repetitive behavior are early symptoms of Alzheimer's disease. Those are two triggers that we look for. However, as a primary caregiver or a secondary caregiver, part of a team, many times you have to repeat what you're asking or telling them in order for the patient to have time to process what it is that you're saying. So you just can't say it quickly and move on. You have to say it, give them time to hear it, and you might have to say it a second time or a third time. And that takes time out of the day. It takes time out of what the task is. We want our dementia patients to do as much for themselves as possible for as long as they can. So if it takes them 20 minutes to put their socks and shoes on, even though you could do it in 3, let them do it. The more they can do for themselves, it gives them a sense of accomplishment. It's a purposeful kind of activity. The more they can do for themselves, the better. But the repetitiveness on the caregiver's part is really important. And again, you have to kind of gauge that according to who the individual is and what their needs are. And those are going to change as they move through the early stages, the middle stages, and the latter stages. How you communicate with them is going to change because they're going to have less and less ability to respond. More their brain is going to be diseased. And as they reach the terminal stage, there may be almost no response back. I've had several caregivers who have said to me that with their primarily husbands in this case, they sit down to dinner and the husband is no longer able to communicate for one reason or another. And they've said they feel like they're sitting at a table talking to a blank wall because they're still talking, they're still relaying stories and things about the kids or what he or she might have done for the day, but there's no response back. And especially with the Alzheimer's patients and some of the others, you get this kind of blank stare that comes across their face. And you don't know whether they're registering what you're saying or not. And that can be a frustrating kind of thing as well. So communicating does change as their behaviors change, as their physical conditions change, their ADLs change. As a caregiver, you have to be creative, you have to be flexible, and you never know from day to day, as I'm sure many of you already know, what's coming. What happens in the morning one day won't necessarily happen in the morning the next day or won't happen an hour later. So that ability to be flexible and creative with whatever is happening within your loved one's life is going to be a great tool to get you through the journey of these diseases. I think I covered all of them. Any questions on the communication piece at all? No? John, I thought maybe you were reaching for your microphone? No? Okay. All right. So I'll speak clearly.
Be sure to unmute. If you unmute, just speak up. Or you can type a question into the chat and I'll read it. I'll read it to Doreen.
Mark, I finally found what was supposed to be at the bottom of my screen is at the top of my screen.
Oh.
So I just happened to hit it with the cursor and it popped up.
I wonder why that is.
I don't know.
The bottom on my screen, so
Normally it's on the bottom of my screen, but for some reason it's on the top right now.
it's very
Does
odd.
anybody have any questions or issues that you want to raise at all?
Okay, I have a question in the chat.
Yeah.
From Janice. She asks, if someone is forgetting nouns, should you fill it in for them or let the person struggle to find the word they need?
That's a very good question. And that's a situation where you have to determine how the patient's going to respond. If it's helpful for the patient for you to do that and they respond okay to that, then go ahead. If you find that it frustrates them more, then you might want to hold back, or you might say, rather than saying the word, you might say, are you talking about X? And ask a question yourself rather than giving them the answer right off. Sometimes it works to provide that word for them. Sometimes you have to kind of hold off and let them struggle just a little bit, but you will know that. You'll have that inner kind of feeling about what is the right way to do that when it happens. Are there other questions?
Hi, Doreen.
Hi, Carla.
Hey, I just wanted to let you know that was a very eye-opening talk. I didn't realize a lot of the things that you talked about. So I want to thank you for that. And I know it would be hard to do in like a 15, 20-minute presentation, but it was very, very, very informative.
Great. I'm glad you got a lot out of it, Carla. It's a complicated topic. I've just skimmed over so much tonight. Many of the trainings that I do are 4 hours or 8 hours. So this is just a really kind of a cursory introduction to several different things that are important for people generally to know about. You can always seek out more information if you have a need to do that. So thank you. I appreciate your comments. The other thing that I will say, and I have one more screen. Oh, let me just go through this quote from President Carter. Oh, no, go back. Hold on a second, get this up. This is one of my favorite quotes. My faith demands I do whatever I can, wherever I am, whenever I can, for as long as I can, with whatever I have to try to make a difference. And I think that's a wonderful quote for caregivers who are working for sometimes years with, I'm going the wrong way, trying to figure out, how to manage what's happening with their loved one. It's a wonderful quote. I loved Rosalind Carter's quote at the beginning, and this is another one that I think is an important one. Let me go on. This is my contact information. If you want to be in touch with me, please let me know how we connected so that I can put some context to it. My phone number is there. I do have a Facebook page, which is DC Putnam Consulting, which is my name here. I also have a website, which is here at the bottom. There's a lot of good basic information on that website about not only Alzheimer's, but other dementia diseases, and a lot of information about caregiving as well. My Facebook page is the DC Putnam Consulting, is geared primarily to caregivers, but not necessarily dementia caregivers. Many times there's other information that's helpful to any caregiver at all. But you can reach me on any one of these contact settings, and I'll be glad to chat with you, or email with you, talk with you on the phone or Zoom.